So hello everyone to all my dear and beloved friends. So who is watching this video. So I am here to help you of some of my learnings regarding H. pylori, which is an important microbiology topic. So I will be briefing you some important points regarding H. pylori. So we will be talking about Helicobacter infections. The reference has been taken from the microbiology textbook of Apurva Sastri. So here the Helicobacter infections. First CO means causative organism is the Helicobacter pylori. The Helicobacter pylori, if you'll see, it is a gram negative, rod shaped, right? Now, what happens here? The Helicobacter pylori colonizes the stomach, right? And this is often associated with peptic ulcer disease and the gastric carcinoma. Now, we'll look into the pathogenesis of the H. pylori. It occurs in a two part. First is colonization of the gastric mucosa. That is very important thing because gastric mucosa, to colonize the gastric mucosa, it's really a tough job because there are so many protective mechanisms out there to protecting the gastric mucosa. HCl is there, mucus is there, right? So many things are working, right? Now, second step is the induces pathological changes out there. Let's see the colonization of gastric mucosa. So, I have mentioned the important points which comes in the colonization of the gastric mucosa, how it colonizes there, how Helicobacter pylori does this, okay? So, if you'll see, first and foremost, the feature is motility. Motility, then comes acid resistance, then adhesins, then the fourth point will be resistance to oxidative stress. So under these 4 points we will cover the colonization of the gastric mucosa. Let's see motility. So motility means the H. pylori is highly motile. Highly motile means what provides motility? Obviously flagella. So it has 4 to 8 unipolar flagella, right? Now, due to this, it remain in viscous environment of the mucus layer. This is the first and foremost feature, right? Next, acid resistance means H. pylori has some enzymes that produces ammonia, and ammonia neutralizes the HCl like a buffer. So what are all those 3 enzymes? Urease, amidase and arginase. Okay, remember this. Urease causes the hydrolysis of urea, causing the release of ammonia, and ammonia acts as a buffer for the gastric acid. Understood? So see, ammonia buffers the gastric acid, right? Now coming to the third part of this, adhesins. It also helps in colonization because few H. pylori bind to Lewis blood group antigen that are present on the parietal cells. Okay, and then also bind to the lipoprotein, right? It means what? There is adhesins in the H. pylori, okay, that adheres to this kind of antigens and lipoproteins. Now, this is the most important part, resistance to oxidative stress. What happens that H. pylori produces detoxifying enzymes. Remember, detoxifying enzymes that protect H. pylori from the free radicals of H. pylori itself and also from the host. What does it mean? Means since H. pylori has to survive there, H. pylori is also this living thing, it should also have been undergoing some metabolism. There will be the byproducts of the metabolism like free radicals, yes or no? That free radicals are being removed, detoxified by the enzymes the H. pylori itself is having those enzymes. That means for the longevity of the H. pylori it works. Okay, and also it protects from the host what? Defensive immune mechanism, right? Now coming to the second step, that was induces the pathological changes. H. pylori induces the pathological changes. The very important thing is that H. pylori secretes VAC-A, that is vacuolating cytotoxin A, and this VAC-A induces what? Vacuoles formation in the cytoplasm of epithelial cells out there in the gastric. There is a CAG-A that helps the H. pylori to modulate the host cells metabolism. This is very important part, that this CAG-A helps the H. pylori to modulate the host cells metabolism. Now third point is lipopolysaccharide of H. pylori is identical to Lewis blood group antigen on the parietal cell, right? So you can understand what will this lead to. Understood? See, fourth point is the very important. I will tell you what happens normally and what's happening in the H. pylori case, right? Normally there is a gastric mucosa, right? The gastric mucosa का glycosylation and sulfation होता है. Remember this, means there is a glycosylation and sulfation of the gastric mucus taking place. Understood? But it increases. Why it happens? Because it increases the protection of the gastric mucosa. Understood? But what happens in the case of H. pylori is that due to H. pylori there is lipopolysaccharide in the H. pylori. Because of that lipopolysaccharide LPS, the glycosylation and sulfation is not happening, and this will lead to the more damage to the gastric mucosa. And also, if you'll see in the smoking and the high salt diet or preserved foods, it supports the H. pylori's growth. Understood? If you'll ask me what is the protective, what to do, so we will see that, we will say that vitamin C and antioxidants is protective. Now coming to the what are the clinical manifestation. The clinical manifestations is acute gastritis, that will be mostly seen in the antrum part. Then you can also see peptic ulcer disease. So here I have just put the part from the Purva Shastri, that mechanism of duodenal ulcer, mechanism of gastric ulcer, right? So what happens? The H. pylori induced inflammation inhibits the somatostatin producing D cells, that increases the gastrin release and increases meal stimulated acid secretion, which further induces duodenal ulcer and gastric metaplasia of duodenal mucosa. What is the mechanism of gastric ulcer? Though not clear, however, it is believed that there is hypochlorhydria despite increased gastrin release. Now, epigastric pain with burning sensation, it is the most common presentation, develops either following a meal, as in duodenal ulcer, means after having meal it will develop, means it's duodenal, and if it's happening in empty stomach, then it's a gastric ulcer. Now coming to the lab diagnosis. The lab diagnosis of the H. pylori is done by two methods, invasive methods and non-invasive methods. Invasive methods is the endoscopy guided multiple biopsies can be taken from gastric mucosa, like antrum I told you is the most important, and also from the corpus, and are subjected to the histopathology with which staining? Warthin steri silver stain is a very important stain, and sensitivity can be improved by the use of immunostaining with anti-H. pylori antibody. Now some microbiological method, gram staining, curved gram negative bacilli with C-gull shaped morphology. Culture, it is the most specific test for H. pylori, however it is not sensitive. Commonly used culture media are Skid Row's media and chocolate agar. Plates are incubated at 37 degrees Celsius under microaerophilic condition, that is 5% oxygen. So microaerophilic condition means that it requires little oxygen, not absence of oxygen, little oxygen for its optimum growth. Identification can be done by automated systems like MALDI-TOF or by conventional biochemical test. Very important, remember it, urease test. Then comes biopsy urease test, and it detects the presence of urease activity in gastric biopsies by using a broth that contains urea and a pH indicator. It is rapid, sensitive and cheap. Some of the non-invasive tests, let's see. Urea breath test means patient drink a solution of urea leveled with non-radioactive carbon 13, then blows into a tube, and if urease produced by H. pylori is present, the urea is hydrolyzed and leveled. CO2 is detected in breath samples by mass spectroscopy. Urea breath test is very popular nowadays as it is non-invasive and is the best test to detect live bacteria, most consistent and accurate test, most sensitive and quick and simple, used to monitor treatment response becomes negative after the improvement. Now fecal antigen assay, it is a non-invasive test again, 90 to 95% sensitivity and specificity, detects both live and dead bacteria, used to monitor treatment response and useful for screening of children. Now antibody detection also you can do by ELISA, which antibody? IgG, is used for screening before endoscopy and for pseudoepidemiological study, right? Coming to the treatment. So what's the treatment? So here are treatment part of the H. pylori, like for active or past, if there is an active or past history of peptic ulcer disease, or there is a atrophic gastritis, or there is a mild lymphoma, or following endoscopic resection of early gastric cancer. So there is a treatment is not recommended for asymptomatic colonizers or primary prophylaxis for gastric cancer because of risk of adverse side effects and development of antibiotic resistance. Usually multi-drug regimens are used. Monotherapy is not useful because of inadequate antibiotic delivery to the colonization niche, right? Success of treatment depends on patient's close compliance with the regimen and use of susceptible antibiotics. So very important, remember this treatment regimen which you have to write in the exam. There is a OBTM quadruple therapy named. O stands for omeprazole, B for bismuth subsalicylate, okay, T for tetracycline and M for metronidazole, and it has to be given for 14 days. Now comes OCM or OCA triple therapy, that is omeprazole, C for clarithromycin and M for metronidazole, or you can also give amoxicillin for 14 days. So it is used only if H. pylori is clarithromycin resistance is low. Only if H. pylori clarithromycin resistance is low, that is less than 15%. So that's the end of this topic. See you in the next video. Thank you for watching.